But she's going to settle the question once and for all. Do contact lenses, are they something that's going to hurt the eye, or are they going to help the eye? So I've been really looking forward to this lecture for quite a while. So please welcome Dr. Brooke Messer.
Thanks. Okay. Thanks for joining us again on a Sunday morning. So I'm Brooke Messer. I practice here in Edina, so I'm local to the panel. Just let me get clipped in here really quick, sorry. And I'm here to talk to you about how we can use contact lenses to help our patient or not hurt them for those that want to wear contact lenses. There's also some things that we can talk about here on how we can decipher, is it actually dry eye that's causing their symptoms, or is it maybe something else with their contact lenses? I have a quick disclosure slide here. So when we talk about dry eye, a lot of these patients think that they are not candidates for contact lenses. And so when we look at soft lenses, let me start over here. With a typical patient, they come in and they say, well, I can't wear lenses because my eyes are too dry. And so those are what I would call our typical contact lens wearers, both soft and GP lenses for the purpose of freedom from glasses. Some patients come in and they're certainly symptomatic from their contacts. And it's our job to decipher, is it from a contact lens itself, parameter-based materials, solutions, or is it truly from their dry eye? So there are a certain number of patients that have these symptoms that have good potential for success in wearing just those cosmetic freedom from glasses type lenses. And then there's our medically necessary contact lens options, which are creating that environmental barrier. And many times this is included in, at least my patients, long-term management. Certain comorbidities, glaucoma, blebs, certain things across the ocular shape side of things, and other diseases can limit the success with these medically necessary contact lenses, but many can do so well. And I'm just going to touch on, are there a few drawbacks, specifically in the scleral lens side of things, like are there things that maybe we would not consider a scleral lens for some of our patients? So I'm going to touch base on that too. So when we examine our patients who present with contact lens discomfort, there's studies that show the best predictors of patients who are going to be symptomatic. And again, these are more of our traditional contact lens wearers. We'll shift into the medically necessary contact lenses on the second half of the presentation. So for this first part, you can assume that we're talking about our traditional contact lens wearers. So our examination goals when they come in, and we want to determine first off, we want to determine if the ocular surface is safe for contact lens wear. So in addition to determining refractive error, make sure that their pressures are good, retinal health, all of that, so that's included in their comprehensive exam, but specifically on contact lenses, first off, we want to determine that the lids and the ocular surface are safe for lens wear. And studies show that the best predictors of those that are going to be symptomatic in their contact lenses are those with meibomian gland dropout, poor quality meibum, and lid wiper epitheliopathy. Less predicting are, surprisingly, tear breakup time and osmolarity. So when we're looking at somebody who's complaining about their contacts, evaluating those meibomian glands and their expression is important to patient comfort. In my experience, additional symptoms that can tell me if my patient is going to be successful in our traditional contact lenses are vision fluctuations, which I sort of touched on already. Those that come in maybe wearing soft lenses of whatever type, and they comment on frequent vision disruption because they're having to close their eyes, take a break, blink a lot. Those types of vision inconsistencies certainly contribute to somebody wanting to drop out of their contact lenses or decreasing their wearing time overall. Excessive lens movement, given it's still a soft lens, and so patients perceive that, soft lenses are soft, and that's why they're comfortable. But an excessive soft lens moving against that underside of the eyelids can certainly stimulate some reactions that we don't like lid papillae that I have listed there. So patients who come in saying like, my contacts have never really been that comfortable, but I just sort of put up with it. Many times excessive lens movement and lid papillae is part of that scenario. The next part of our examination goals would be to, again, rule out a poor fitting contact lens as the reason for symptoms rather than the dryness itself. Many patients present with, we see those patients every day that present with that discomfort without really many signs. And so part of this certainly could be a poor fitting contact lens, and simply switching parameters based on some ocular measurements can improve their symptoms as well. In the contact lens wearing experience, there are many tools that our patients use, and all of those things can contribute to their comfort. There are contact lens cases. In the GP world, we call the little tools, they're plungers, so they're insertion removal tools. They're solutions, they're topical lubricants. If they're using a preserved artificial tear over a reusable contact lens, that preservative can certainly attach to the lens surface, build up over time, and can contribute to contact lens discomfort. So many times we encourage our patients to actually bring everything with them. So, bring your whole man purse or your bag of contact lens goodies, and we'll examine the cases. And while this isn't one of my patients here, but many times, I'm sure you've all seen those cases that come in and they are grimy. Some of my patients do like those reusable cases that we give them, to send out with a set of diagnostic lenses or something, and there are those flip cases rather than the screw tops. It's proven that those flip cases are less resistant to biofilms and things growing along the edge and getting inside the bowl of the lens. So for patients who are reusing their contact lenses, GP wearers, orthokeratology lens wearers, monthly, reusable or custom soft lenses, they should not be in a case that has a flip top. It should definitely be a screw case. Those are a little bit more resistant to biofilms getting into the bowl of the lens. But in general, again, this is just, we should be looking at the whole picture. What's the case look like? What's the hand soap that they're using? What do their fingernails look like? Are they grimy as well? Those are all things that can introduce something into the ocular surface that can contribute to their symptoms. And then lastly, we want to, as I mentioned, properly analyze the ocular surface and select the appropriate lens design. And you don't need many fancy tools to properly analyze the surface. I have a phoropter listed there because obviously we want to measure their vision to select lens power. And as we alluded to this morning in the panel, binocular vision is helpful too. So a quick screening, especially those that seem to be symptomatic in all types of contact lenses, no matter what they've tried, and they come in and they have that list of, I've been in brand A, brand B, brand C, brand C again with a different material or a different base curve, different diameters, things like that. Doing a quick binocular workup to examine phorias that may be causing their eyes to feel that strain that they're interpreting as dry eye symptoms. That can certainly help us rule out part of their wearing experience. Topography is helpful, and you can grab those K measurements, but if you don't have a topographer, something that gives you a corneal diameter and their central Ks are helpful in selecting lenses. And then of course our slit lamp, our most valuable tool in evaluating the lids, the cornea, to make sure again that ocular surface is ready for contact lens wear. Another tool that is helpful in examining a patient with contact lens discomfort, whether it be dry eye or we're trying to decipher what that is. We have the contact lens dry eye questionnaire. It's an 8-question survey that helps identify those patients that could benefit from adjusting from improving their contact lens symptoms. So it kind of it dives in and helps filter out dryness versus contact lens symptoms. And so patients who have what we call the cutoff score, 12 points or higher, those are the ones that would benefit from us adjusting their contact lenses, whether it be a parameter, power, again, that's up to us to examine and filter that out. And an improvement of 3 points is considered significant in improving their symptoms. So those that improve by 3 points are definitely noticing a better comfort in their contact lenses. So when it comes to contact lenses, do they hurt or do they help or do they do nothing to the ocular surface? What do we know about how contact lenses affect the structures in our eyes that support our tear layer? So first off, we're going to talk about the goblet cells, and then we'll move on to the meibomian glands. When it comes to goblet cells, when we look at the way that contact lenses affect the number of goblet cells on the ocular surface, symptomatic contact lens wearers, we do see a decrease of that goblet cell density by about 1/3. And so definitely some changes there. Asymptomatic contact lens wearers, perhaps it's because their lenses fit a little bit better. They're not squishing on that ocular surface quite as tightly. No change or decrease by 10 to 13% or so. We see the initial change in goblet cell density over the first 6 months of contact lens wear, but thankfully, if the contact lenses are changed, contact lenses are reduced to part-time for a short period, we introduce a medication that can help with goblet cell density. Thankfully, our goblet cells can come back. They can re-increase in that goblet cell density to improve the comfort of the ocular surface. And so there's still a lot to learn about how contact lenses affect the goblet cells. And when I was creating this lecture, I was sort of digging like goblet cells, contact lenses, decrease in goblet cell density, scleral lenses, soft lenses, and there's really not a whole lot out there. There's much, much more research done on meibomian glands, and that's probably because from as far as we know now, when a meibomian gland is damaged, it's a more permanent or it's more difficult to recover that structure versus goblet cells being able to at least bounce back over time. And so again, while we keep the goblet cells in mind and that, that slippery mucin that they create, the meibomian glands may be the structure that we need to keep a closer eye on when it comes to contact lenses, because that's certainly, again, harder to recover after the damage has been done. So when it comes to meibomian glands, how do contact lenses hurt the eye, or what can they do to damage the meibomian glands? The thought process here is that inflammation from the contact lens surface, whether it be dryness, deposits, allergens, on the contact lens surface, that can alter the meibomian gland morphology. So that's the source of the irritation is not so much the contact lens itself as it is what happens at the surface of the contact lens, and then that inflammation gets into the glands and causes that truncation or the alteration in the meibomian gland morphology. And unfortunately, decreasing or stopping the contact lens wear altogether does not improve meibomian gland appearance, at least to what we know that we can do now. There are those isolated cases, or there's some data showing that, hey, maybe we can get some meibomian glands to show back up on meibography, but that is still, I would say, less secure or less likely to happen than those that have damage and then the damage has been done. So again, we need to keep those contact lenses fitting well and keep the ocular surface as clean as we can to limit that inflammation that can damage the glands. Some studies, I was again doing some research, how fast do these meibomian glands change with contact lens wear? And the study ranges show about within the first 2 to 3 years, that's when the most change happens. And so some studies have shown that after that 2 to 3 year mark, there's less change to the meibomian glands with continued contact lens wear. So we might think, okay, if the patient presents to me, they've been wearing contact lenses for 20 years or 10 years, maybe the damage has already been done, and as long as we keep a healthy contact lens wear, it's not going to get any worse. Other studies show that with continued contact lens wear, the meibomian gland morphology continues to decrease or continues to change in a detrimental way. Part-time wearers, thankfully, show less change or minimal change, more similar to no wearers. But in all of my research on how and experience with how contact lens wear can affect the meibomian glands, there's overwhelming data to support that daily disposables have less of an impact compared to reusable lenses. So that's another reason for us as optometrists to get on board with prescribing daily disposable contact lenses, especially with the expansion of parameters in daily disposable lenses now and improvement in materials. There's so many options, multifocals, torics, high spheres. We're really getting to that point where there's fewer and fewer patients that cannot wear a daily disposable contact lens because of their prescription. And again, because the daily disposables, you're getting rid of that daily exposure to the allergen or the buildup of the allergen, the buildup of the deposits on the lens surface, that by decreasing those insults, the inflammation is going to be less across the contact lens surface, and then therefore decrease the insult to the meibomian glands. When a patient presents with contact lens discomfort, some of us, we may not be able to see any signs that point to dryness. Their meibomian glands look pretty good. Their tear meniscus looks healthy. But still, 1 out of 4 patients present to us with contact lens discomfort without any signs of dry eye. And on this this contact lens discomfort flow chart here, we have 2 ways that we can approach contact lens discomfort, one by altering the environment and then also altering the contact lens parameter. And that's what I'm going to talk about next, is how do we select the right parameters for our contact lens patients. And these next 2 slides to me are the money slides. So if you want to improve your patient's comfort in just our traditional soft contact lens wearers. These are the ones that I feel have made the most impact in my practice in the way that I change how I prescribe just your traditional old soft contact lenses. I think the number of patients that, patients come to us, our clinic is called the Cornea and Contact Lens Institute, so they type in contact lenses Minnesota and we're toward the top of the list. And so patients come in and say, well, I came here because it appears that you guys specialize in contact lenses or you focus on contact lenses, and my contact lenses have never been comfortable. And then I look at them and they're wearing a lens that barely covers the limbus, maybe even rides a little bit high with intermittent limbus exposure between blinks. And the lens is way too small for the cornea diameter. Perhaps they're outside the bell curve, their cornea is a 12.4 diameter, and this lens is barely covering. And there would be actually a good candidate for either the largest soft lens that I can grab in a sort of mass manufactured way, or a custom soft lens so that we can properly drape that limbal area. And so it's easy to have a go-to lens. Everybody loved lens A, or I always grab lens B for my spherical lens wearers, but so it's easy to have that go-to lens, but there are patients that are going to be outside that bell curve, and that's a super easy switch. You want to see about 1 millimeter of drape over each side of the limbus when you're looking at a soft lens. Another one is contact lens sagittal depth and compared to the anterior chamber depth of the eye. Anybody fitting scleral lenses here? Okay. Would you fit so my next bullet point here is there's a 700 micron range in soft contact lens sagittal depths. So would you fit a scleral lens that was 700 microns too shallow? Oh yeah, Justin, would you fit a lens that's 700 microns too deep? Why are we fitting contact lenses that could potentially be 700 microns too shallow? So there are, from the standard in the spherical lenses, this data, the 700 micron range of sagittal depth in soft lenses, this data is coming out of Pacific University at the optometry school there. And I have the slide of the actual sagittal depths, but it's not my right to share it just yet. But I did feel that it was okay to share with you that huge range in soft contact lens sagittal depths with some of the newer daily disposables being on the much deeper side and some of the monthly reusables being more on the shallow side. And so that goes to show too, as the daily disposable side of things, they've done their research on contact lens comfort and they've realized that, hey, maybe we've been fitting soft lenses too shallow all this time. And this is what's contributing to lenses that they move too much because they're not draping properly. And then we're getting lid interaction, papillae, contact lens discomfort, and intermittent limbal irritation from that lens movement. So again, keeping in mind the sagittal depth is of the cornea. So if you're working with a large corneal diameter, typically those patients have a deep sagittal depth in their anterior chamber. So the larger they get, the deeper they go. And so not only do we need a large corneal diameter, but we need a lens that's deep. And so again, you can watch for that data to come out. I don't know exactly when it will, but I would anticipate sometime in the next handful of months we would see that in some sort of publication on showing the mass difference between the different types of contact lenses that are out there as far as the depth and the drape. With these two things in mind, when it comes to corneal diameter and anterior chamber depth, to me, the base curve of a contact lens has become less important. It's more about fitting by sagittal depth. Across all contact lenses, we fit scleral lenses by sagittal depth. We fit orthokeratology lenses by sagittal depth. And soft lenses should be looked at the same, that if we have a deep cornea, we need a lens that can drape over that. We need a deep lens to drape over it. Unexpected poor vision. This is another one where patients just come in and they say, well, I've never really seen that great with my contact lenses, and I just think that maybe my vision just isn't that great or isn't that good. And that's usually a drape issue, and that's where changing the lens modulus can help. So if we have a lens that perhaps is a little bit too stiff for perhaps a shallow cornea, and now the lens is intermittently tenting over with each blink, so when they open their eye, the lens kind of floats up a little bit, and then they close their eye and they push the lens against the eye, so they have a moment of clear vision, and then as soon as that lens sort of regains its stiffer modulus shape, then it sort of changes the way that it sits on the corneal surface, and that changes their vision quality. And so that type of cornea, again, is likely outside the bell curve, that perhaps it's shallower, And we need something that fits a little bit better. So a softer modulus will drape better over those shallower eyes if you can't get a lens that's small enough. So a smaller lens is typically shallower, so that would be my first change, to look for a smaller diameter. But another option would be changing the modulus so that it's softer and it drapes better over that atypical corneal shape. Next is solution sensitivity. Again, moving more and more to the promoting daily disposable contact lenses. Many long-term contact lens wearers will burn out on solutions over time, especially exposure to BAK. And so if we cannot get them into a daily disposable contact lens, they need to be on a hydrogen peroxide disinfecting system. But daily disposables would be my first choice, just getting them out of the solution game altogether so that they have that fresh lens every day. And then again, we already sort of talked about contact lens movement, but looking at the way that the lens moves on the eye, they should just have those quick limited movements, enough to sort of pump a little tear back there and resettle in. Excessive lens movement decreases their vision, it decreases their comfort, and it interacts with their lids that could potentially cause some increased papillae or GPC. If you have a patient who's been doing really well with their soft lens wear for a long time and now they come in with new excessive lens movement, to me that tells me that their lid is likely getting sticky and producing some mucus. And many of the times if you flip that lid, you'll see that they've developed a case of GPC. So again, on an otherwise happy contact lens wear, GPC is probably the cause of now that lens moving around a lot. Do I just hit play to play the video? Let's see. So this is a case of a lens. So you can see this lens barely covers the limbus there. And it's moving quite a bit laterally in this case. It's decentered toward the nasal, so there's a little more coverage nasally when it settles in, but you can see it barely covers the inferior limbus. And this is a patient that just came in for their annual eye exam saying like, well, my contact lenses aren't that great. I only wear them part-time. I must have dry eye because I can't wear my contact lenses the whole day, when actually if you looked at that and we analyzed this lens fit, we would know that the lens ride's high. So if it was a previously fitting good lens, perhaps there's some lid stuff going on. There was a lot of movement. So to me, it says that this lens is too shallow for the eye. So I need something likely larger in diameter and a little bit deeper in the sagittal depth of the soft lens. And so again, the goal is to have the lens drape about 1 millimeter on either side of the limbus. So now let's talk about pathologic dry eye and contact lenses. So traditionally, soft contact lenses and pathologic ocular surface disease do not mix. And so the contact lens now shifts from a vision correction to an environmental barrier to decrease the sensation of air, debris, wind, keeping moisture across the ocular surface. Our options are soft contact lenses, or excuse me, soft bandage lens as a temporary option. So that's how I use bandage lenses now for patients who have something like maybe ABMD or other cases where we have sort of a delicate epithelium, where traditionally soft bandage lenses were an option. They've sort of shifted out in favor of a scleral lens, but I still use a bandage lens for those cases like recurrent erosions, acute recurrent erosions, or abrasions that I would expect to heal normally and allow them to be without contacts or back to their normal wearing habits. But when it comes to long-term therapy, scleral lenses are now part of my regimen. And so it's those best patients that are good candidates for scleral lenses are going to be those that have those chronic symptoms, chronic redness, chronic eye watering, light sensitivity, burning. It's basically those patients that they come in, they're wearing sunglasses, and their eyelids are red or their lids are a little bit chapped because they have constant watering out the corners of their eye. Those are the patients that really get a huge bang for their buck, if you would, or a great response to scleral lenses. This is a list here. It's certainly not all-inclusive. As we know more about scleral lenses and learn more about the ocular surface and more about systemic conditions that affect the eyes, that list continues to grow. When you have a patient in the chair and maybe they have one of these diagnoses, maybe they don't, like keratoconjunctivitis sicca, for example, it's hard to decide if this patient would be a good candidate for scleral lenses depending on how severe their symptoms are. Certainly some would put the lens on and they just give you that, oh, this feels so good, right? They have that amazing response, where others, they put it in and they like can kind of feel it. I don't know, maybe it's a little bit better. My approach to these types of patients, where you have them in the chair and you think, gosh, maybe this patient would be a good candidate for long-term scleral lens wear as part of their therapy. I'll put a lens on in office, and I just put on a trial lens that looks fairly good. The vault doesn't necessarily have to be perfect, and the edges don't have to be perfect, but just something that vaults the cornea and vaults the limbus to an adequate amount. And I'll have them go sit out in the waiting room for 15, 20 minutes. A lot of the times that's enough for the patient to decide, like, hey, like I'm actually having a pretty good response to this. Or they'll come back in and they'll say, I don't really think my eyes are feeling that much better. Sometimes we actually have to get the ocular surface tuned up just a little bit with maybe like Restasis, cleaning the lids, considering maybe some punctal plugs, and then add in the contact lens after. So sometimes we need to take a two-step approach, getting them to the point where their ocular surface can actually support a scleral lens. But many times, the majority of times, when you have somebody on this list in your chair, you put that scleral lens on just as a diagnostic. We call it like an acceptance trial. And they sit there and they're like, oh, this is so good. And they're, it's just an amazing tool to be able to offer to patients when they give you that response. So Don Ezekiel is what we would consider one of the godfathers of scleral lenses. And back in 1983, he had this quote here where he said that corneas that are disrupted, distorted, or dry due to corneal deformities or ocular conditions are best suited for a haptic lens. And he was, even back in 1983, spot on with his description of a scleral lens and its applications. For those of you that are unfamiliar, a scleral lens is designed to completely vault the cornea and the limbus and land evenly on the sclera. And really the magic in this lens system is that fluid reservoir that sits in front of the cornea but behind the contact lens. It negates the corneal irregularities for better vision, and it's not just our irregular corneas that have ectasia or post-LASIK or corneal transplants. It's those that have irregular corneal surface from ABMD, scarring, chronic corneal staining. That fluid reservoir would negate their irregular corneal surface as well and give them better vision. The scleral lenses are made with high oxygen material, that fluid reservoir to protect the eye, and customizable haptics so that we can perfectly fit that lens to the front of the eye. On an irregular cornea, when it comes to fitting, how do we fit scleral lenses differently when it comes to our irregular cornea group and our dry eye group? Typically, on my dry eye patients, I'm probably fitting the lens with a slightly larger diameter just to give them more coverage so that less of their ocular surface is exposed to the environment. For me, I keep the vault on the safe but minimal side of things. If we have too much vault, in my experience, it's just more space for gunk to get under the lens and cause clouding of their vision. So I'm going to fit it as shallow as I can. That's what I would consider safe, both over the apex and the limbus. And heavy focus on alignment to the ocular surface because I don't want those edges digging in anywhere where it's causing a mucus production response. So in an irregular cornea patient, if the edges look pretty good and the patient is comfortable and I don't see any insults, then I'll let them go. Whereas on a dry eye side, I'm really working to make sure that I have near perfect alignment or as perfect as I can get. Thankfully, we have some technology in scleral lens technology when it comes to the shape, where we can create custom lifts. So there's a precision lift or a microvault. There's a few different terminology around it, but this is an OCT here in the top right. You can see that lens edge digging into a temporal pinguecula, and we can add down at the bottom something called the precision lift or microvault to lift over those conjunctival surfaces and actually cover that. So we can cover a pinguecula without impinging on it to improve the appearance of the lens landing on the eye, and not only improve the appearance, but also improve the comfort and the conjunctival health as well. We talked a little bit about iPrint Pro in the panel before, so I'll just keep moving for sake of time. But it is a molded scleral contact lens that fits perfectly to the eye. So you can see here, this patient that I did the impression on, she had had strabismus surgery, and the little indentations in her conj there are where the sutures were, or the scarring over the sutures on the muscle surgery. But she also had keratoconus and significant dry eye from her chemotherapy medications. And so by allowing this, we got that perfect alignment. We didn't impinge over those conjunctival abnormalities. And one thing I love about the molded scleral lens technology is that you get that perfect alignment to the sclera there. Another great piece of technology in scleral lenses is the hydropeg, which a tangible hydropeg is a coating that's bonded to the front of the lens to create a more deposit-resistant surface and wettable. So it actually attracts water to keep the lens, so it improves their tear breakup time over the contact lens. It decreases the incidence of deposits to keep the lens more comfortable and their vision more clear. So those patients who have a hard time producing tears, they're still going to have vision fluctuation from a dry contact lens surface, just as they would without the contact lens. Where the tangible hydropeg attracts water and keeps water on the contact lens surface so that they have better vision and better comfort as well. So what do we know? What happens to scleral lenses after patients have been wearing them? The tear film, after 8 hours of wear, we see a decrease in osmolarity, a decrease in OSD scores, which is a good thing. And there is some studies that show an increase in MMP9, and our thought behind that is that perhaps the lens being on the eye for so long, or that same fluid being behind the lens on the eye, perhaps there's maybe some stirrup of some inflammation there. When it comes to the patient experience, scleral lenses provide a significant improvement to the quality of life. The VFQ-25 quality of life scores in patients who wore scleral lenses, their quality of life scores nearly doubled, and their OSDI scores went from severe to mild. So again, these patients are having an amazing response to the lenses. And in a 2007 study on patients with graft versus host, 33 patients had previously failed with other therapies, and nearly all reported improvement of their symptoms by wearing a scleral lens. Lastly here, I'm just going to talk about what are some things that we need to worry about when our patients are wearing scleral lenses, and what are some things that would maybe make me hesitate when I'm fitting a patient in a scleral lens. I would proceed with caution in very inflamed eyes or patients who are likely to get inflamed. We need to make sure that they stay under control, and we talked about that yesterday about patients who we fit in scleral lenses need to maintain their other regimens to keep their eye under control. And eyes that have scarring, corneal transplant, intacts, they seem to spur up things like this here. So this is a patient of mine who sort of fell off the wagon for a while. I didn't see him for a long time. Then all of a sudden he came back with some eye pain and had this huge instance of vascularization and inflammation there. And that's something that I had to, we started steroids, got in touch with his corneal surgeon and things like that to make sure he was monitored. But one thing that we have to keep in mind is, are the patients going to abuse these lenses if now they all of a sudden feel normal because they can see so well? Are they going to revert back to maybe their old soft contact lens habits where they're maybe abusing the lenses, wearing them too long, not cleaning them properly, potentially sleeping in them? Thankfully, some of these things can be cleaned up with either a better lens fit or medications, but intacts are one for sure that you need to keep a close eye on these patients and probably see them every 3 to 4 months to monitor for vascularization. Lastly, patients with poor dexterity and poor hygiene, again, those are things that could make inserting a scleral lens more difficult, or at least on the dexterity side of things. And they could introduce, if they put the lens on and they get bubbles behind the chamber, now they have a spot of desiccation from those bubbles. And so patients with poor dexterity may not be a great candidate for a scleral lens. Here's another patient with some vascularization due to a poor fit scleral lens, and we did some changes, and you can see it's a little bit brighter, but you can see a significant decrease in the vascularization with just improving the scleral lens fit. So he had excessive vault over that area, which led to some neovascularization. Another one would be excessive vault over the limbus. So this patient has conjunctival prolapse there, and when you look at a topography and you have the elevation map and you look at an area that's significantly shallower or decreased in elevation, that's a spot where you might see some conjunctival prolapse on a scleral lens fit, and so that can kind of key you in to what to watch for and where. So this patient had some conjunctival prolapse, and there's 2 camps on conjunctival prolapse. Some feel that it's not a big deal. Others get a little bit worried because you can get some neovascularization under that area of the conjunctival fold. And so, again, just watch that area or decrease the clearance in that area if you can. And then lastly, it's the significant conjunctival impressions from the lenses being too tight. We can actually abrade the surface and cause some conjunctival staining or even mild conjunctival abrasions from lens edges being too tight. So if you see those gutter type looks, that's something that we need to make sure that we modify the lens fit or even move them into like a molded technology to align perfectly if you can't get it done with your traditional scleral lenses. So sorry for running over for a few minutes, but in summary, many symptoms of soft contact lens wearers can be relieved by a better fitting lens, and that scleral lenses are an amazing tool for us as long as we monitor them and keep a close eye on them to make sure that the lens stays healthy. So if you have any questions, I'll be around for the rest of the morning. Thank you for being here.